Thank you very much, Samir. It's again my pleasure to be with you today, and many thanks to the board of the Moroccan Society of Cardiology, who has accepted actually to have this joint session with the annual meeting of the Moroccan Society of Cardiology. You know that the PCI for CTO is a very rapidly evolving area thanks to the development of techniques and equipment, as well to the increased training of the person. I have no disclosure for this talk. Now, there's no doubt that PCI for CTO is one of the most challenging procedures in the cath lab nowadays. It is technically difficult to treat. This is procedure time intensive. Most of the time it's complex. It requires significant contrast load, and it is associated with a certain rate of complications. Now, as to the success rate, historically it was about 50% when we started doing this procedure many years ago. But now this success rate has dramatically increased to more than 90%. Just to show you the rate of success in this clinical and very large registries, the Progress CTO, which is an American registry, 88%. The Open CTO, which is an international registry but initiated in the USA, 86%. And the experience of European colleagues with the Euro CTO Club, the success rate is 88%. Does that mean that we should give into temptation and attempt all CTOs because of this high success rate? This is a question asked by Galassi in one of his editorials. And the question, of course, not at all. You should all the time try to go through a rational analysis, taking into account the clinical, anatomical factors, but also another important parameter, which is the operator's experience. Now, in the same time, there is no doubt that CTO is associated with adverse outcome. And this is one of the big registries you certainly remember of the SCAR Swedish registry that has included more than 200,000 patients with PCI. And among that large registry, there was more than 14,000 patients with CTO. They have actually looked at the outcome of these patients over the years after 6 years of follow-up. And it is very clearly shown in this graph that CTO was associated with increased mortality. So it's not benign to have a CTO in your coronaries. And by the way, the conclusion of that trial was that there is an increased mortality in patients with CTO, and that association was most prominent, and this is really important, in younger patients and those with acute coronary syndrome. Another trial, this is a Spanish trial that has looked at the impact of having a CTO on the recurrence of ventricular arrhythmia in ischemic secondary prevention implantable ICD in patients who had an ICD, and they have looked whether patients with CTO have a comparable outcome to those who didn't have a CTO. And this is the finding of the study. They have looked at the freedom from appropriate ICD therapy according to the presence of CTO, and they concluded to find a higher risk of ventricular arrhythmia recurrence and mortality after 5 years compared to patients who had CTO in green and those who didn't have a CTO in blue. So CTO is not a benign thing, but that does not imply you should proceed with PCI in every patient with CTO. In practice, there are questions that every operator should ask before embarking in such a complex procedure. And the first question is there an appropriate indication for doing the procedure? There is a large registry, Chinese one, that was conducted in Fuwai Hospital. I don't know if you have heard about this hospital. This is the hospital that has the world's largest cardiovascular center with more than 1,200 beds and 13 cath labs. In that registry, they had more than 42,000 patients included, and among them, they have identified something like 2,600 patients with CTO. And what they have looked in that registry, they looked at the 5-year incidence of a composite endpoint of all-cause death, all MI, and all hospitalization due to heart failure, which is quite interesting. They have looked at the appropriateness of indications. So they have actually looked on the indication, it was appropriate or inappropriate, and compared the two groups. Inappropriate indications means that the patient had a CTO in an occluded artery with unviable myocardial territory, or the patients had symptoms that not related to that occluded vessel, or the patient had a syntax score with more than 32 with left main, which is an indication for surgery, or if the patient had syntax score more than 22 with triple vessel disease. So they have compared first the success rate, it was 75% in both groups. They have looked at the 1-month clinical outcome in terms of all-cause death, cardiac death, MI, etc. And you can see that actually there was no difference between the two groups regarding all these parameters. But look at these figures now when they have analyzed the results and looked at the 5 years clinical outcome of those same parameters. You see that actually all-cause death, cardiac death, MI, they were significant in favor of the group who has appropriate indication. They have looked at death, MI, heart failure, and still the same. It's a higher death, MI, and heart failure in patients with inappropriate indication, all-cause death the same, MI the same, and heart failure the same when it was an adjusted analysis or adjusted. The conclusion of that important registry is that we have really we need to be careful in terms of indication, try to avoid an appropriate indication to perform CTO, and that the comparison between the two groups did not appear at 30 days, but it did appear at 5 years. So if you're doing a CTO PCI with an appropriate indication and inappropriate indication, you are not serving your patient, but rather you're harming your patient. Second question, what is the likelihood of success? And for that, you need to look at your patient's demographics, lesion characteristics, operator expertise, and of course, your cath lab setting, the availability of equipment, devices, whether or not you have an imaging modality like IVUS, etc. And back to the SCAR registry, when they have compared the population that have a successful PCR for CTO and those who had a failure, you see that actually the population that have success have a much better outcome. So success of CTO PCI affects considerably the outcome. And Galassi in this trial, he also looked at the same thing, but based on the level of LV dysfunction, and he found actually the same thing. So if you have a failed CTO PCI, then you will compromise your patients with more MACE risk at follow-up. He also found actually patients with older patients and diabetic patients have that higher risk compared to the rest of the population. What he did find in that study, and this is quite interesting, he did actually analyze the success versus failure in patients based on LV function, whether the patients have any function more than 50%, between 35 and 50%, or they have an LV function less than 35%. And surprisingly, he found that actually the most benefit was observed in patients with LV dysfunction with an ejection fraction less than 35% in terms of all-cause death, but also in terms of functional improvement, and mainly in terms of improvement of LV function with a clear here improvement of LV function from 29% to 42%. So don't be afraid of attempt to do PCI in patients with LV dysfunction if the indication is appropriate. Now, of course, there are traditional angiographic predictors of poor outcomes. So you know already, if you look at the anatomy, whether or not you have a high success probability or not to cross and to perform successfully the procedure. Those predictors are long gap, no tapering stump, side branch at conclusion, at the site of the occlusion, vessel tortuosity, calcification, osteal location, poor distal vessel visibility, and bridge scores. The most famous score is the J score that you certainly, the JCTO score that you certainly know. But are there a whole list of other scores, the CT Rector score, CL score, Pro CTO? I think you have to rely to one single score in order to determine the probability of success of your procedure. There's also the Oro CTO Kessler score. I would not go through the details of that. I would just straight to something quite interesting that was published quite recently, which is a consensus manuscript. There was one American manuscript that was published in circulation, but there is, in the same time, there was another European expert consensus document. And I will just give you just a sense or an idea about both. Let's start first by the American expert consensus document. 7 key principles were really emphasized. The first one is that the principal indication for CTO PCI is to improve symptoms. Dual coronary angiography is really important. Use of catheters also. There are 4 CTO crossing strategies: the antegrade wire escalation, antegrade dissection reentry, retrograde wire escalation, and retrograde dissection reentry. I would not go through the details of that. The change of equipment and technique increase the likelihood of success and improves the efficiency of the procedure. And importantly, centers and physicians performing CTO PCI should have the necessary equipment, expertise, and experience to optimize success and manage complication. Now, this is the European consensus that was published almost at the same time. And the European consensus, in the European consensus, there are more details in terms of expertise. For example, it is clearly shown that that at least 100 CTO PCI per year must be performed by an operator to reach a success rate more than 90%. So really important. And it is recommended that centers and operators performing fewer than 30 CTO procedures annually, they should refer their CTO patients to a more experienced operator. Now, regarding the retrograde approach, a minimum of 50 retrograde procedures, 25 as second operator, and 25 as first under supervision might be advised before a cardiologist becomes an independent retrograde operator. And again, a very important point regarding the leadership and whether you should have several operators in the cath lab, or maybe you have to designate 1 or 2 operators in the team in order to improve the expertise. Third question, what is the approximate cost of the procedure? This is an important question, particularly coming from our environment in Africa and with limited resources countries. And this question was addressed very recently in a manuscript about the Open CTO registry, which is an American one. And what it was shown is that the procedure is quite long, 120 minutes, 3.4 in average guiding catheter were used per procedure, 10 guide wires, 5 angioplasty balloons, 2.6 stents, and a cost of approximately $15,000 US, which is a huge thing, particularly if you compare that to what we can afford in our continent. Let me give you an idea about how we face that problem in clinical practice. This is the case of a 50-year-old man who had an inferior MI with successful thrombolysis, an ejection fraction of 55%, which is not that bad. So there is not much damage to his myocardium with limited inferior akinesia. Coronary angiogram shows severe stenosis of the RCA and proximal LED CTO. The decision for CABG was taken, but the patient has declined to go to surgery. This is the anatomy. You can see here the occluded LAD with just the poor runoff. You see it barely here distally. This is the right corner artery, which was open, but with a very ulcerated, severe lesion, and it gives a very nice collateral circulation to the LAD. So we started by treating the RCA, and then we tried actually to open antegrade the LAD, but it was not possible at all. And then we have to decide to go retrogradely through the freshly treated RCA. And you see here, look at this wire going back from the right corner artery, and then it was externalized later on. And then we, of course, we continued after that. It was quite easy later on with a very final good result. Now, we did evaluate actually such procedure that we did perform with Dr. Sotoro from Japan. And, you know, this is what we had to use as equipment: 12 wires, 2 microcatheters, 320 ml of contrast, 4 DES.
Wow.
And basically, we did use actually what we usually use in 4 conventional PCIs. But, you know, don't worry, that's not the classical scenario, and didn't happen that way all the time. Quite often, by the way, it's just 1 wire, 1 balloon, 1 stent, as it was found by a recent trial, where actually in two-thirds of the cases, that's what you need. A balloon or a microcatheter, of course, in addition to that. And this is just quite another case where you have an occluded RCA due to stent thrombosis, quite old actually, and we needed just to have a dual injection in order to try to see where the RCA is, and the distal runoff, 1 wire, 1 balloon, and final good result. I will finish with an algorithm that was published quite recently. So in the presence of a CTO case, if the patient is not symptomatic, medical management it is recommended. If the patient is symptomatic, now you have to look if the patient has a multivessel disease or not. If there is if there's no multivessel disease, a CTO of course is indicated. But if there is a complex anatomy, then you have to look whether or not the patient is a good surgical candidate. In that case, you have to send the patient surgery. If not, the patient can benefit from a peritoneal approach with CTO PCI. Now, if there is any other indication for surgery, like for example, stenosis or any other reason for taking the patient to surgery, of course, that's a clear indication for CABG. Now, in conclusion, appropriate indication for CTO PCI is essential to maximize the benefit for the patient. Success of the procedure makes a lot of difference compared to failure, and impacts considerably the outcome, and patient's demographics, lesion characteristics, operator expertise, and availability of equipment materials are the 4 cornerstones of success of CTO PCI. Thank you for your attention.